next talk, Dr. Neha GOEL. Can you please speak on the retinal findings in cardiac and neurological diseases? Please come. Yeah, we'll have some discussion at the end of the session now.
Good morning, everyone. I welcome you all to Delhi. And first of all, I'd like to thank Dr. Gopal for including me in this instruction course, which I think is very, very relevant and very important to us. I'll be talking about retinal findings in cardiac and neurological diseases. So we hear this often, the eyes are a window to our soul, but they are also very organically a window to the circulatory system. And probably retinal imaging is the quickest and easiest and most non-invasive way of directly looking at the blood vessels anywhere in the body. Apart from that, the microvasculature of the eye is also unique in that it has a high circulatory resistance, and hence it becomes highly susceptible to any alteration in the systemic circulation due to cardiovascular diseases. The retina requires more oxygen per gram of tissue, even more than the brain. So under any stress or pathological condition, the changes in the eye microvasculature may actually precede the systemic changes or occur concomitantly. And again, as I said, these can be easily visualized during a fundus examination. So let's talk about some of the disorders which we encounter. Acute vascular diseases, arterial dissection, not very common but life-threatening, and though they usually present to the cardiologist, but they may on retrospective history taking reveal episodes of amaurosis fugax. A painful Horner's is something which should alert you, and of course ischemic optic neuropathy, ocular ischemic syndrome, or even CRAO may occur concomitantly or may precede the episode. More commonly we see patients with infective endocarditis where we are sent referrals, and rod spots are the classical manifestations. You can see these white-centered hemorrhages which are actually aggregates of the platelets, fibrin, and the emboli. Apart from the rod spots, you can have septic emboli in smaller vessels leading to cotton wool spots or BRAO, in the larger vessels leading to CRAO, and sometimes even ophthalmic artery occlusion. These may even present with white patches such as focal retinitis or the embolic retinopathy or subretinal abscess, and even CNV has been reported secondary to these emboli. Endogenous endophthalmitis might happen in infective endocarditis. It is commonest with Staph aureus and more common in the right eye because of the straight path from the heart, and rarely you may get papillitis or optic neuritis. Takayasu arthritis was just being talked about, and there are three distinct patterns which you can get: the classic hypoperfusive retinopathy or the Takayasu retinopathy, or since these patients have associated hypertension, you can get hypertensive retinopathy or a mixed retinopathy as well. They may also have episodes of amaurosis fugax, and remember, because the artery and the vein have a common adventitial sheath, they can also present with BRVO, even though it is a arthritis pathologically speaking. Now, giant cell arthritis, as Professor Harry has ingrained, that any patient over the age of 55 who presents with amaurosis fugax, diplopia, or visual loss with AION, CRAO, celoretinal occlusion must be suspected of having GCA unless proven otherwise. A simple ESR or CRP can alert you, and it may be instrumental in saving the other eye from permanent visual damage. Now, coming to subacute or chronic vascular diseases, the cerebral, cardiac, as well as the retinal arterioles are similar in terms of anatomy and physiology. If you look at the literature, then you realize that the risk of stroke is actually 2 to 3 folds higher in people with hypertensive retinopathy, independent of cardiovascular risk factors. Hence, we must encourage our physician colleagues to send more and more referrals for evaluation of hypertensive retinopathy. So starting with the carotid artery disease, this is the commonest we see where the ocular findings actually alert us to the presence of a systemic disease. And in acute cases, apart from amaurosis fugax, you can get these Hollenhorst plaques, which may sometimes even be asymptomatic, or as here you can see these plaques, or they can cause a arterial occlusion, either a branch or a central. In chronic cases, we get what is known as venous stasis retinopathy, and this can easily be confused with central retinal vein occlusion. But I'll show you some cases here. The typical picture is the sludging of the blood in the veins. The veins become darkened, as it is classically said. The hemorrhages are not as much as CRVO, and the angiography angiography clinches the diagnosis. So venous stasis retinopathy may in fact be an earlier stage of the full-blown ocular ischemic syndrome. So this was a 55-year-old male. The right eye was asymptomatic, though you can see some venous dilatation here in the inferior part, and this is the left eye. So if you look at the veins, you can see the darkened color and the thickening of the veins. Very subtle hemorrhages. These are deep retinal hemorrhages, and on FFA you say delayed filling. Along with this, typical small vessel telangiectasia and ischemia that you see in the periphery. Also mid-peripheral microaneurysms, especially if the patient is not a diabetic, these should alert you to the presence of venous stasis retinopathy or even early ocular ischemic syndrome. So this patient was then sent for cardiac evaluation, and in the left eye there was 100% occlusion or stenosis in the ICA. The right eye had about 70%. So at this stage, the intervention cardiologist can prevent the sequelae such as stroke. Now, another lady, right eye, had media haze because she was 65 because of cataract, and this was the left eye. Again, you can see the darkened veins, very subtle hemorrhages, and on FFA here you can see asymmetric filling, and again the small vessel telangiectasia and ischemia along with microaneurysms in the mid-periphery. Now she again had complete ICA blockage on that side, which was the left side. Unfortunately, despite PRP, she went on to develop neovascular glaucoma and had lost vision in this eye secondary to the glaucoma. So next, coming to systemic hypertension, the retinal vasculature is actually protected from fluctuations in systemic arterial pressure because of the autoregulatory mechanisms, but naturally they fail beyond a particular blood pressure. So in acute hypertension, the choroidal vasculature may be affected more because of this reason. The retinal vessels, they maintain their vascular tone longer than the choroidal vessels. But in cases of chronic hypertension, the changes are more in the retina. So here we know the classic hypertensive retinopathy and the stages, but I'd like to say here there's a wide intra and inter-observer variation, especially, like in certain institutions where you have to grade the patients or classify them into categories, being in the armed forces or because of their employment. So it's a good idea to take photographs and then document the stage they are in. So these are some of the patients we see. Grade 3 hypertensive retinopathy without involvement of the optic nerve. You can see complete and incomplete macular stars here, a preponderance of cotton wool spots. Now, coming to some of the less commonly encountered cardiovascular conditions. So congenital heart disease, the children have said to have more vascular dilatation and tortuosity in the cyanotic type of congenital heart disease, mainly because of polycythemia and hypoxia. And this has been seen to reverse to an extent after surgical repair. Now, this was a child we had seen long back who presented with proliferative retinopathy, and he was a known case of teratology of Fallot, and we hypothesized that the chronic ischemia had led to this kind of proliferative retinopathy. So apart from that, cardiac myxomas again are rare, but we must be aware of the Carney complex where they may have ocular myxomas as well. And cases of pulmonary hypertension may again present with venous stasis retinopathy. So a word about the future. As we just discussed, the retinal changes may occur concomitantly or precede the cardiovascular catastrophes, and we may actually, allow interventions which may be life-saving for the patient. So just looking beyond the fundus and a high clinical suspicion can save many of these patients. A word about the integration of AI in retinal imaging. So along with a lot of cardiac imaging and cardiac biomarkers, there is now a system to risk stratify those patients who are at risk of developing either heart failure or stroke, and retinal imaging is a part of that scoring system. In fact, in many of the service hospitals, I'm aware that they have the cardiology department, without our intervention, have the non-mediatic smartphone-held fundus cameras, and they are using this to stratify their patients as well. Now coming to the second part of my talk, the retina is also an extension of the brain, as we know, and retinal manifestations of structural and functional deterioration are interlinked with the development of neurodegenerative disorders. In fact, extensive work has been done on this, and I feel that we use our OCT, we underutilize our OCT in the field of neurodegenerative disorders. Now the retinal changes may occur, I'll just take 2 minutes more, as a primary pathology or secondary to the transsynaptic changes. As we know, the entire pathway involves the retina as well. Now, these surrogate markers are very exciting because, first of all, they can predict the onset of disease. They can be used repeatedly to follow up the patients non-invasively. There is no ionizing radiation, unlike a CT scan or an MRI, and no use of contrast agents as well. So, Alzheimer's is the one on which the maximum work has been done, and the peripapillary RNFL loss is said to be the most sensitive indicator. This is a global loss as compared to Parkinson's disease, where it is more of a temporal loss. So OCTA has also been used to quantify the retinal vascular network in the deep and superficial plexus, and it has been seen that the FAZ is enlarged. Interestingly, this correlates with the mini mental state examination, the MMSE. So really we need to work in conjunction with our neurology departments even more. Multiple sclerosis, as we all know, the association of optic neuritis, but I'd just like to highlight the microcystic macular edema. This was one of our cases. So here you have cysts in the ONL, which can be confused with edema, but they do not leak on FFA, and there is this typical appearance on OCTA, which can be quite dramatic as well. Suzak syndrome is another neurological disease which can present with multiple BRVOs, and we may be the first to diagnose it. Last word about the neurocutaneous disorders. So we know of neurofibromatosis type 1, where usually they present with optic nerve gliomas, but we've reported a case of peripheral retinal ischemia. Tuberous sclerosis can present with astrocytic hematomas, either diagnosed cases or we may be the first to pick this up. This was a large symptomatic astrocytic hematoma with exudative RD, which led to loss of this eye in a young child. And then the very obvious Sturge-Weber syndrome. Here they can have ipsilateral leptomeningeal hemangiomas along with the choroidal hemangioma. So these are not cases of VHL, but this is what a retinal capillary hemangioma looks like. So finally, this case presented with bilateral macular retinitis, and honestly we didn't know what it was, so we sent it to retina under their diagnostic and therapeutic challenges, and there was acute macular retinitis. Within a period of days it progressed to complete loss of the retinal layers, leaving only the ILM intact. And along with the expert opinion, the patient turned out to be a case of SSPE. Unfortunately, he was a young boy and lost his life within the first year, but the retinal changes manifested first, and this was one of the earliest reports of that condition. So to take away, the retina is actually the only portion of the CNS which is optically accessible for high resolution imaging without the use of radiation at a relatively low cost and without the use of any contrast. So the association with neurodegenerative disease severity have been demonstrated, and these actually provide a lot of possibilities for disease assessment and even therapeutic interventions in the future. Thank you for your patient hearing.
Thank you very much.